We're excited today to present the home health survival test, home health and hospice survival test. 4 questions to ask about your agency. My name is Robert Love. I'm with ContinuLink Procura. I'm out on the West Coast, and we're thrilled here to have our presenter, Richard Chesney from Healthcare Market Resources. I've known Rich for well over 10 years, and when I helped run an agency, when I needed information, data, competitive data, market data, trending data, Rich was always the guy to help us with the information to make those strategic decisions. Rich studies this information. He has it in the macro sense or on the micro sense in terms of regional information related to home care and other post-acute operations. And so who better to share this type of information than having Rich? So we're thrilled that when we asked him to present to our group, he agreed. And we're absolutely thrilled again to have Rich Chesney on the line. So at this time, I'd like to turn the reins over to Rich and begin the presentation.
All right, thank you, everyone. This is Rich Chesney. Thank you for taking time out of your day to talk for us to talk about the home health and hospice survival test. Just quickly on your screen, you should be seeing the agenda for today. We'll talk about what we hope to accomplish, a little bit more about my background, an environmental context for this discussion, and then our 4 survival test questions for home health and hospice. They'll each have 4 questions. And then what are the implications of the answers to those questions, and what conclusions can we draw from our discussion? One of our goals today is to talk about how the healthcare landscape is changing for home health and hospice, not only for those industries specifically, but for the people around us that are the source of our referrals, because if their agendas change, our agendas will change. I'm not going to be going into the specifics of all the different legislation and regulatory efforts that we're seeing, but more to provide just an overview of what it all means. Then we're going to provide you these 4 questions, which is a self-assessment tool for your organization to look at your prospects for future success. And lastly, we're going to outline some next steps for your organization going forward and what you should be looking at. I've had over 20 years now, close to 25 years in the home care industry, 35 years in planning and in marketing, and I've got an MBA. And currently, I'm the president, as Rob said, of Healthcare Market Resources, which is a market research firm serving the post-acute market. And we help home health agencies, hospices, skilled nursing facilities understand their market, their competition, and their referral sources. And our clients use our data in strategic and market planning, in benchmarking, in sales targeting, key account development, and in compliance assessment. Skilled nursing facilities and physicians. So let's begin to look at this changing landscape. And first and foremost, if we take a somewhat longer view, what we've seen over the last 4 to 5 years has been significantly reduced margins. We've had rebasing, we've had case mix creep coming up for hospice, differentiated reimbursement, meaning that we're looking at getting paid differently for one set of conditions for the same service, i.e. patients that have been on service less than 60 days versus those that have been on service more than 60 days. And managed care there is in quotes. Obviously, managed care is growing overall. And for most of us, it is a much less profitable part of our business. And then the other thing we'll be The other thing is the dual eligible demonstration project, which is rolling out on a state-by-state basis, which is effectively another form of managed care, and with it comes a major shift in profitability on that segment of business. There's been obviously the sequestration, which is effectively a price cut for 2016 on home health. We're looking at a case weight shift on the therapy side. High value therapy cases, those 20 visits and more, will be receiving less weight, and some of the less intense visit levels will be serving more. So depending on where your organization is, it's going to have a varying impact on it. And then we've got the productivity adjustment as well that's still sitting out there. And the bottom line is that it's almost like death by 1,000 little cuts, a little bit at each time. The big area, though, is a shift from payment for volume per payment for value. And we all have heard about the statement by the current Secretary of HHS stating that it is their goal to move more and more of the reimbursement that we're going to be receiving from the government to be based on value and not volume. And they're on a fairly aggressive timetable, putting out lots of demonstration projects to do this, and it affects the entire healthcare delivery system. The most obvious for value-based purchasing for home health, which there was a prior webinar on. We've got the accountable care organizations and the concept of population health management. We've got capitation, whether it be voluntary, which were the bundled payment initiatives, the models 1 through 4, even though only models really 2 and 3 affected the post-acute sector, home health agencies in particular. And then coming up in the current proposed rule for hospitals is mandatory bundled payments for hips and knees, which are two of the largest, highest volume DRGs, and those will be for 90 days worth of care. The hospitals will be responsible. That is guaranteed to change a lot of the patterns for care that we've seen in the past. The net result of this is that folks, particularly hospitals, are going to have more and more dollars on the line that is going to be tied into things that they cannot control, that is not under their roof or within their four walls. They've got readmission penalties that is beginning to change the behavior. And as I said, the mandatory bundle payment for hips and knees, I think, will take that to another level. It will mean for in most markets a narrowing of the provider referral lists. And we've seen, when we look at our data, we will see for some major hospitals 20 and 30 agencies that could be getting referrals. On the nursing home side, we can see 50 or 60 nursing homes. I think that what's going to happen is those lists are going to get dramatically reduced into a more manageable few that the hospitals can work closely with. And we think that, it's going to be a matter of you've got to get to the table and be on the initial list if you want to be participating in this market. There's more data transparency. More data is being published, coming out, making public so that people and hospitals can make decisions. We're looking at readmission rates, and we've got the star ratings. Now, the star ratings, whether you agree with them or not, and whether you think that they're of value, is not the question. The challenge has always been with the OASIS data on Home Health Compare is that there were too many ratings and there were too many categories, and they changed and people couldn't understand them. Star ratings, its power is in its simplicity, right? It's very easy to know, and people will assume that 4 stars is better than 3 stars. Whether it is or not is not the subject for debate. It will be the market that decides what's going on. We're going to see increased regulatory scrutiny and increased more rules. We're still dealing with the challenges of face-to-face on the home health side, but really the regulatory scrutiny has probably most affected hospice because they've been asked to grow up and become an adult very quickly at a rate of change that they've not been used to, nor do they have the background and the resources. But we think that's only going to continue given some of the bad apples that have come into the barrel. The goal is going to be to drive unnecessary care and cost out of the system, and that's going to be the driving force. So let's go on and talk about our 4 questions. And those 4 questions are going to be in the areas of organic growth, post-acute networks, reimbursement, impact, and efficiency. Now, the first question for home health is, can we grow organically? And that growth organically is really based on 2 factors. One, to grow, you either have to take share or find new sources of patients. And depending on how mature your market is, finding new sources of patients can be either easy or very hard. We've looked at this over time, and I will tell you that there is an enormous range in terms of, in the home health space, in terms of home health utilization. We have a place like South Dakota or Montana that uses about 3% of the Medicare fee-for-service beneficiaries use home health in a given year. On the other hand, if we go to Texas, that number is over 15%. So there's almost a 4 or 5 times difference in the utilization of home health. Now, I'm not saying that the Texas's 15% is the ideal, but it does show you the variability that you've got in that market. So if I'm sitting in Montana or South Dakota, my ability to find new patient sources is going to obviously be much greater than it might be if I'm sitting in Texas or Florida or Louisiana, which are some of the high utilization states. How concentrated is my market? There's some economic theory that says that markets tend to concentrate over time. And so what we look at there is to look and see what the top 3 or 4 providers have in terms of combined market share. And if that combined market share is generally over about 65% combined, we generally say that's a concentrated market. That means that referral sources have pretty much determined who they're going to be giving their business to. And as we all know, getting referral sources, once they're made a decision on a particular provider, usually takes a major service breakdown to get folks to change. So that's going to be a real challenge, getting taking away market share, and you're going to have to be that much better than the competition in order to get people's attention once they've settled on someone or not, and are not generally rotating their business. We talked about also earlier in the changing landscape the shift of the hospitals taking responsibility for all the post-acute expenditures after discharges for 90 days on hips and knees. The care patterns for that are dramatically different, and in fact, some markets tend to use home health more, and some markets tend to use skilled nursing. And we've seen that, particularly with some of the voluntary bundled payment markets, that those patterns of care are shifting. Years ago, I had an administrator from a rehab hospital tell me the following, and he said, "Rich, it's real simple. On the west, they go home, and on the east, they go to a facility." And that's not totally true, but it is that there are these historic patterns that exist in terms of how people use care. And now that we're putting money behind this, i.e. the hospital's ability to make more margin if they are able to spend less than the norms that Medicare is giving them, is going to be the incentives to get people to change. If you recall, if you take a step back from the physician's perspective, particularly the primary care physicians, who oftentimes are going to manage these patients coming out of the hospital post-discharge, if they go to the nursing home, it's the nursing home medical director that's managing that patient. Unfortunately, if they go home, it falls upon the primary care physician to manage that patient. And most of them see that as added work for which they get no reimbursement. And in fact, when we looked at some recent data on physician home health certifications, we see that most episodes are not certified, i.e. the physicians are not billing for signing the treatment plans for those patients. So from their perspective, it's not something they want, but if the hospitals are going to start forcing it, they're going to have to be able to play along. Lastly, one of the other opportunities is, can we increase revenue per patient? That means less LUPA rate, less LUPAs, higher case weight, and more research. And very candidly, that's what the industry literally focused on from 2005 to 2010, where we saw all those things take place. Case weights went up, which is why we had case weight creep adjustment. Research increased. Very candidly, most of those now have begun to level out. LUPA rates have declined from where they were. The industry average about 5 years ago was in the slightly over 10%. I just looked at some data for 2013, and it's 8.8%. But very candidly, that was also 8.8% in 2011. So the LUPA rate is essentially flat right now. But there is one area of opportunity, because if you go look at the LUPA rates by state, you're going to see dramatic variations, with some providers being down around the 5 or 6% rate. Clearly, there is also some gamesmanship here, because several years ago someone did some research, and out of the 12,000 agencies at the time, 900 of them had 0 LUPAs, which we begin to wonder about the way those businesses are being run. That being aside, this is one area where we think there could be some opportunity for folks to be more diligent, make changes to their systems, and get patients that with front-loaded services to make sure that they don't end up going back into the hospital and they don't end up with a LUPA. On the hospice side, the question of market maturity, once again, is there. We see on the hospice side, we measure that by looking at patients served divided by Medicare eligible, and what we see once again, is about a 200 or 300% variation in utilization, which means some markets such as Delaware or Iowa or Florida or Arizona or Colorado are fairly mature. On the other hand, other markets like Hawaii or some of the markets in the upper Midwest are very immature, where there's a lot of room to grow. Interestingly enough, one of the best examples I've got is that when you look at New York City has one of the lowest utilization rates of hospice in the country. It's very interesting is that if Queens County, if I go across the border to Nassau County, which is across from Queens, the hospice utilization rate goes up 40%. So there's these incredible opportunities if you're in the hospice, depending where you are geographically, to be able to grow and find new patients. But clearly, if we look at all the patients that die in facilities, such as LTACs and nursing homes and rehab hospitals, less so, and at hospitals themselves, when all is said and done, there's still a lot of opportunity, regardless of where you are in the country, for hospice to grow. Several years ago, we did a piece of research, and what we saw was that for Medicare patients, about 7% of the patients who left the hospital alive died within 30 days. And that's not really very surprising. It's not a big number, but they're not dying on hospice because hospice referrals coming out of the hospitals generally average in the 1.5% to 2% rate. So as you can see, there's a lot of opportunity there. Also, once again, market concentration, ability to get market share. But the big opportunity for hospice is to increase length of stay. Now, while the new reimbursement proposed system that's been announced does reward, make shorter lengths of stay slightly more profitable, they're not where you want to be. Anyone who's familiar with hospice knows that it takes at least 30 days for hospice really to be able to, as we would say, work its magic and be able to help the patient and the family come to an acceptance of their fate. And also from an economic perspective, the savings to the rest of the healthcare system generally last somewhere between 60 and 90 days. That's the sweet spot of hospice. Unfortunately, the median is only about 17 days. So there's an enormous opportunity here to begin to hopefully change behavior and get folks to come on to the service earlier. And there's some great examples of that. For example, there's a health system in La Crosse, Wisconsin, Gunderson, that has spent 20 years getting their community to buy into advanced directives, whereby almost everybody, all the senior citizens, have signed advanced directives, and they've got a system that information is communicated. The net result of that is that when we look at the Medicare spending per beneficiary, that advanced directives and the implementation of them, in fact, has kept cost per patient for Medicare patient very low in La Crosse, Wisconsin. So that's proof that this system can work if it starts with a community effort to really look at abiding by the patient's and the family wishes to decide how they would like to leave this earth. Once again, markets that tend to be more heavily with cancer tend to have more shorter lengths of stay, but we are seeing some of the impact of the failure to thrive and issues like that coming off the table, and limiting some of the patients that historically, maybe inappropriately, have gone to hospice. Also, patients that tend to be in assisted living facilities and nursing homes tend to have longer lengths of stay. than do patients that are at home, for sure. And very candidly, our research shows that hospice historically has been a white ethnic mix service. Historically, blacks, Hispanics, Asians, Polynesians, because of cultural reasons, have not embraced the service as much as some of the other ethnic groups. So depending on your ethnic mix in your market, you may or may not, you have an opportunity to begin to change attitudes over time to help people become more accepting of hospice. One of the big trends, as we know, is the use of palliative care to get people into the position where they can consider hospice. Medicare just announced 130 hospices that will be participating in the Medicare Care Choices model over the next several years. That's the beginning of paying hospices to engage folks in a dialogue and to be consultants to them as they go through the disease process of their terminal illness. Obviously, the secret here is to get those patients from palliative care into hospice. And in fact, I have heard one of the hospices that already has a Medicare demonstration grant, Hospice of the Bluegrass, which is in Kentucky, they've been doing very well on that conversion and getting folks once they've had them on the palliative care. Obviously, we know for those that are in hospice, when the subject of hospice is brought up, it's a very challenging moment. It's very time-consuming process for the physician, which makes them sometimes resistant to broach it. It's also not something that they've been taught to deal with easily in medical school. So obviously, if you're introducing the concept of hospice in a time of crisis, family dynamics being what there is, it becomes a very tedious and tenuous relationship versus a palliative care model, which relies more on an advanced directives and a more weighted, considered, rational discussion at an earlier point of time versus a crisis situation where the doctor says, I can't do anything for you, you might as well go on hospice. So there's real opportunity, we feel, in the palliative care to bring folks into the hospice much earlier and therefore begin to address that length of stay issue. Managed care organizations have a real incentive to get patients when they have a terminal illness to get them on hospice because the hospice patients are likely costing them more than what they're getting paid on a per member per month basis. And managed care organizations have advanced illness teams that are helping people through this, but our research seems to indicate that they're not doing that great of a job to date in converting their enrollees and getting them to use hospice. Financially, it's a better deal for them. They just have not been able to find the magic formula, so hospices should be looking to partner with managed care organizations to help them get these patients and introduce the concept of hospice. We've talked about on home health. We've talked about the concept of the hospitals now having more at risk, which is basically leading them to form post-acute networks. MedPAC did some research, and they said for home health that about 58% of all episodes start with a hospitalization, but only 38% of all episodes come from that. So 58% of the admissions, 37% of the episodes. Obviously, what we're seeing is community-based referrals having more research And one of the questions is going to be whether that's going to continue on a long-term basis. So one of the things that you should be looking at is whether I can play in the post-acute network, whether I can get into them, and then if I can't, how much more business is going to be left for me to capture if I'm not able to join a post-acute network. Because, you know, in the past, everybody has tried to be all things to all people. That's going to stop, and you're either going to be in the network or not, and if you're not, then you're going to have to find some other sources of business. Very candidly, with the exception of the certificate of need states, there is now an incentive for hospitals to go back into the home health business. Several years ago, in the mid-2000s, when we did some work for the National Association for Home Care, we had in excess of 20% of the agencies that were there today were hospital-based. Today, that number has dropped to 11%, and they've basically have dropped out of the business because of the challenges involved with being in the home health business over the last couple of years. With the advent of readmission penalties and mandatory bundling on hips and knees, hospitals strategically, I think, are going to be re-looking at whether this decision on a make or buy basis is to how they develop home health capacity, whether it's going to be theirs to own and run, or whether they're going to partner with people. I believe that, you know, that they should be having a stable of agencies in order to keep everybody on their toes. But unfortunately, many hospital administrators are control freaks, and they're going to want to have control. And I think you're going to see, particularly, there's some talk going on, particularly MedPAC proposed that we do away for post-acute providers with freedom of choice. And so that right now, many of the hospitals' lawyers are afraid of a lawsuit, so that, and the discharge planning departments hang their hats on this, we got to give patient choice. Those days may be numbered. The hospitals are making a very strong argument is you can't expect me to be held accountable for performance for providers that I have no influence over. So do not be surprised if you begin to see the freedom of choice going away in certain circumstances. And so I think that's going to change behavior, and it's going to increase the rates of captive agencies capturing more business. You know, in many cases, we saw several years ago, we looked at only about 35 to 37% of the hospitals had a single provider that did more than 65% of their home health referrals. So that there was a lot of diversity. I think that over time, you're going to see those percentages change. The proposed bundled payment, mandatory payment for hips and knees, I think will dramatically affect referral patterns on a geographic basis. We looked several years ago at the ratio of home health to skilled nursing facilities, those referrals on a geographic basis. We saw that in South Dakota, 70% of the patients leaving the hospital went to a SNF, and 30% went to home health on that ratio. When we got to Louisiana, 34% went to a SNF, and 66% went to home health. Obviously, given the fact that a home health stay is about 40% of the cost of a skilled nursing stay, there's going to be real incentive on a market-by-market basis for hospitals to begin to shift their referral patterns. And those referral patterns may take two different forms. One, patients may go, in fact, directly to home health that used to go to a skilled nursing facility, or they may go to a skilled nursing facility for a much shorter period of time, and then get discharged at maybe day 13, 14, or 15, and then still require some home health. That's still a less expensive alternative than them spending 30 days in a skilled nursing facility and not needing any home health when they walk out. So we believe that this is going to cause a shift and probably will be a plus for home health agencies in those markets that historically have been very SNF dependent, which tends to be a lot of the upper Midwest and some of the other states. The Southeast has generally used, Louisiana being our example in the data, has tended to use home health much more readily than other places in the country. One of the other trends we know is the fact of whether hospitals have been buying up physician practices, in particular cardiologists, as they begin to bring these physician practices into the fold, upgrade their electronic medical record systems. There's going to be a greater ability to monitor where that doctor is sending their referrals and who he's doing business with if it's a physician-owned practice. I think that some of the computer systems like Epic are making that very easy for the hospital to monitor, and so even the community referrals for these physicians that are owned may in fact begin to get steered to a set of preferred providers, and in particular the captive provider. How do you get into a network? That's going to be a challenge. We believe that it's really going to be based on performance. The things that are going to be important are going to be readmission rates and emergent care usage. Obviously, that's what costs the hospitals the money. The ED is a direct door into the hospital, and so the goal is if you keep them out of the ED or the emergency department, they'll never get admitted. Patient satisfaction scores, they don't want any rub-off of a bad experience with a provider they told you to go to, and that affecting the scores for the hospital. Those patient satisfaction scores are part of the hospital's value-based purchasing, and so once again we've got here where they're going to be very concerned about how a patient's experience with your organization could affect their reimbursement. Obviously, quality is going to be another comparison. One of the things that came out in the recent legislation for the ACOs was the ability to do away with the 3-day rule for the hospitals, but they're only going to allow them to go to SNFs that are at least 3-star. All right, the skilled nursing facilities have a similar rating system to home health. It's been in place much longer, and I think there's a little bit more differentiation. But the bottom line here is that what we need to see here is the fact is that your quality rating allows you to get referrals, and if you don't have that quality rating, you're not in the running. So here's another vehicle that's going to be a differentiator. Also, one of the things, if I'm in the bundled payment world, or I'm in the population health side, or I'm part of an accountable care organization, resource utilization is going to be very important. If I'm in a managed care organization as well, can I get the job done with less resources, with a lower PERG score, less, so that home health agencies are going to be judged on how they use their resources, which has never been something that people have looked at. Financial stability, whether you've got the wherewithal, hospitals are going to want to get in bed with a limited number of providers for the long term. Relationships are something that are hard to cultivate, and once they've got one, they don't want to lose it because you don't have the financial wherewithal. If we look at the durable medical equipment business and competitive bidding, one of the things that happened there was that potential bidders had to submit financial forms of their balance sheet and income statements in order to be considered as part of the bidding. Expect that as part of the qualification process to get into a network that you're going to probably have to submit some financial paperwork so that people know that you're financially stable. First and foremost, it's going to be your ability to be a clinical equal with the sophistication to be able to talk the language of the hospital and talk to the other members of the post-acute world. Integrating your information systems into theirs is going to be another key determiners. And then compliance. You know, are you compliant? How do your PEPR score, how do you fare on your PEPR scores versus other providers in your market? They obviously are going to want someone who is on the up and up and doesn't want any red flags. Hospices are in a different role within the post-acute network. They historically have not gotten their best referrals from the post-acute market. It's usually been the last minute in the hospital, send them to a inpatient for inpatient care. Those have not been the most attractive referrals for the skilled nursing facility, for the hospices. And very candidly, fewer of the hospitals have hospice capacity as we look across the country. So I think that market's going to be a lot more open to partnerships. Once again, hospice's opportunity is to be able to help managed care organizations, folks with bundle payments, ACOs, and then hospitals themselves on their value-based purchasing metrics such as mortality rates, readmission rates, and per beneficiary spending to help people perform better than the average by increasing their utilization of hospice. So knowing where your hospitals are on their value-based purchasing metrics, their mortality rates, their readmission rates, their per beneficiary spending is important in understanding their utilization of hospice and where it could be increased. Once again, there's the opportunity here for inpatient transfers to get the patients off the books, quote unquote, so they don't die in the hospital. Relative to their value-based purchasing metric, that does not help them with their 30-day mortality rates, but some managed care organizations do look at mortality rates as being indicative of quality. Most importantly, it's the opportunity for community-based palliative care. And with something like the Medicare Care Choices model, which is designed to address patients who have actually had exacerbations of their terminal illness and been hospitalized at some point in the prior 12 months before they become eligible for this program, there's a real opportunity here to work with the hospitals to identify those patients who are symptomatic of their condition and therefore may be in a mindset to begin to join a palliative care program. The obvious benefit to the hospice is eventually being able to work with the family and the patient to move them on to hospice when the conditions are appropriate. So there is another opportunity there for hospices to be working with hospitals in helping them be more financially successful. We've talked about the reimbursement changes and understanding what that means to my agency, my market, and my competition. For the 2016, we're going to look at a shift in high therapy cases that's getting less weight, and then some of the lower intensity therapy cases are going to get a higher weight. So, you know, depending on what your mix of business is and that of your competitors, you may find that some folks are losing 1 or 2% off the top of their revenues and getting their margins hit. Interestingly enough, this is such a big issue. On the nursing home side, about 50% of the cases are that go through the nursing homes are at the high therapy levels. They've found the way, the gamesmanship to be able to justify those high levels. I think going forward, you're going to see, particularly with hospitals being paid a bundled rates for hips and knees, they're no longer going to permit patients to have those high levels of therapy usage at home. They're going to want to get them out and into outpatient therapy as soon as possible. In a former life, I ran a home health agency, and we had a very prominent hip surgeon who took a capitated deal for Medicare Advantage patients with an insurance company in our local market. And he came to my home health agency and basically said, you have 5 visits before I get that patient ready so that I can send them to my outpatient therapy, which is in my offices. Oh, and by the way, I have a van so that transportation is not an issue for those patients. I'm not going to say that all the patients are going to go there, but I think you're going to see a trend to even home health over time, losing patients much sooner and not being able to keep them as long. So I think that's going to have obviously an impact on your therapy mix, on your therapy case weights, and obviously then drive down your margins in there as well. The real ticking time bomb is the dual eligible demonstration projects. 16 states are signed up and moving forward. Another 4 are still in negotiations. When we look at that data nationally, about 1 out of $3 that is spent on home health is spent on a dual eligible. This is a big deal. And that varies dramatically. We've got Montana, which is around 20% of the dollars, but I've got California that's close to 50%. So these dual eligibles are a very, very big part of home health. And so if that volume is shifted over time to these dual eligible managed care organizations, there's going to be a significant negative impact on home health agencies. In fact, most of you do not know the number of dual eligibles that you serve, because in fact, if they were Medicare, that's all that went down on the sheet, and the secondaries may or may not have gone into the computer system. We've been able, through the data that we get from the government, able to identify by agency the number of dual eligibles that have been serving, and so we've been able to help our clients understand how much volume is at risk. This is a big deal because I think we can expect several things going forward. If that goes to these organizations, I think you're going to see limits on research. They're going to watch. You're going to have to justify that. In the past, research have been one of those things where it's the rooster guarding the hen house. No one's been holding you accountable, and getting a doctor to sign. We all know that they may not give that the detailed thought that they should. Once again, you know, obviously the payment for managed care is considerably less. Even if you can get a capitated rate, you're probably going to take at least a 20% hit off the top of your current reimbursement rates, if that. So that's another real threat coming down the road. Cost rebasing we still have. Sequestration is coming. The Impact Act, which could have been a real positive because it would have helped prove that patients do just as well in home health as they do at the facilities, whether it be rehab hospitals or nursing homes. Very candidly, that assessment and kind of which was leading up to a site-neutral payment system that people have been talking about, to some extent has almost been bypassed by the new proposed rule for basically making mandatory bundled payments for hips and knees, which are the bulk of the, a big piece of the reimbursement here for the cases coming through. I think if it changes for hips and knees, the rest of the clinical cases will quickly follow behind in the change in their referral patterns. Value-based purchasing for home health, I think we know that the big threat there may not be the actual scores, but are going to be the withholds and the impact on cash flow, and whether people have got the monies to be able, if they're not a good performer, to be able to stay in business when they're getting that much, anywhere from 5 to 8% taken off the top line of their business. I think there's a real effort on the part of Medicare, whether it's unwritten and unsaid, unspoken, to get rid of the small providers. We do not need in excess of 12,000 home health agencies. We've got about 1,400 hospital systems or health systems in the country. You know, I think that the ratio from a delivery perspective is completely out of whack. And I think that there's an effort to keep raising the bar in order to move the small providers out of the business. ICD-10 coding transition, I don't see that. I'm hopeful that Medicare will be that will be a smooth thing. But you know, there's a lot of physician practices not ready for this, and it could be that some of your insurers, particularly your small ones, are not going to be ready, which are going to cause delays in cash flow, which for agencies that are living on a hand-to-mouth basis, this could be a real challenge. On hospice, we've got the new two-tiered rate and the increased reimbursement at end of life. But very candidly, as we begin to study this, you know, I think this is only a first step. Very candidly, and speaking knowledgeable about this, said we're not going to probably for agencies that are over the cap, for hospices over the cap, this is have a big of an impact. I think this will be more psychological in terms of people dumping patients sooner. One of the things we saw several years ago when we did some research on hospices that were over the cap is that they had a high rate of live discharges, which was caused by them basically getting rid of patients when they hit 180 days. So you may see people not taking patients that they used to take because of their perceived risk of the lower reimbursement. Very candidly, I think if you were to do your analysis, some reimbursement may be better than no reimbursement. Sitting in the offing, though, is still the MedPAC recommendation to move hospice to managed care and put it under that umbrella. Obviously, that's a major threat, and you know, in some markets, that could be 20 or 30% of your business, if not more, that are currently in managed care prior to them coming onto hospice. And it is likely that in the short term, all you would see would be reduced rates and nothing more in terms of benefit. Obviously, given all this downward pressure on margins and on reimbursement, one of the things that we've had strategies is, can you become more efficient? You know, do you benchmark yourself against your local competition? That's your standard, because they're facing the same challenges you are. What we like to say is that the patients you get, when you get them in the disease process and how long you get to keep them, are all out of your control, but they have a significant impact on your metrics. And so comparing yourself to other agencies that are in a similar situation under a similar healthcare delivery system becomes a very important process to know how well or how poorly you're doing. Are you optimizing your visits by discipline. From a financial perspective, you've got to match resource utilization against reimbursement. If not, you're going to go out of business. As the Catholic sisters are well known to say, no margin, no mission. And so overall, you've got to figure out, are you using your resources appropriately? For those agencies that are on a pay-per-visit, there's a natural tendency of clinicians to manage their income by maintaining a patient load and not giving up patients if they don't have one to replace it, because they're going to suffer financially if they're not able to visit that patient. For some of the folks that are expert at doing this pay-per-visit, which is a strong incentive to get productivity, on the other side, it requires that agencies have a strong clinical supervision team that is looking at when it is most appropriate to discharge a patient and get them off service sooner rather than later once they've met their goals, and not letting the clinician keep them on service so that they can maintain their income levels. That's a real challenge. Also, financially, LUPAs are, an enormous opportunity. As we talked about earlier, they're nationally at 8.8%, but there's still an opportunity to probably bring them for many agencies with some folks supervision down into the 6% range, by just being more diligent about front-loading visits, making sure that missed visits are done, and a whole range of operational efficiencies in order to get those LUPAs up to full episodes. Are you managing your episodes well? Are you evaluating the use of therapy based on clinical triggers in your patients? Are you using nursing? Are you still using nursing to do admit visits on therapy patients, which is basically a wasted visit? That the therapist should be in a position and should be trained to be able to do that. So it really means changing your clinical practice. I know that can be very difficult. That can be challenging from a political perspective. For non-clinicians to talk to the clinicians about changing clinical care is always a difficult conversation. On the other hand, if the survival of the agency is at risk, I think those are the types of difficult discussions you've got to have. You need to be looking at your visit levels per patient per week by discipline and comparing it to your competitors. Are you providing the right level of service, too much service? Obviously, there's a new quality metric that Medicare has been using, which is looking at the number of professional visits in the last 2 days prior to death. They believe that those correlate well to end-of-life satisfaction with end-of-life services. But when all is said and done in hospice, the most ineffective thing we do is short-stay patients. They use up a lot of resources and with very little financial return. So the real success in hospice to cost efficiency is to increase length of stay. So you need to go home and you can take this presentation. I'm sure ContinuLink is going to make it available. You need to take the test. And if you can't get 3 out of 4, then you need at least 3 out of 4 questions being answered positively to have a chance to be able to survive long term. And even if you pass today, we think that bar is going to continue to rise and be much higher in the future. If you get a failing score, you're going to have to look in the mirror and ask some really hard questions. You're going to need to think about a merger, particularly if you're a nonprofit. If you're a for-profit, you may want to think about selling. Or the other added thing is just basically to wind the business down, phase it out, and when you get to a point where you can't, your census is too low, it's shut the lights off and close the door, and that's it. So in looking at it, you need to look at it. If you've got a passing score or prospect, you've got to start making changes today. Some of these things are happening now. Some will be happening in the future. The message is business is not the same. Business will not continue to be the same. It will be different. So some quick conclusions. Value-based purchasing is here to stay across all segments of the healthcare industry, and you're going to be impacted whether it's directly or indirectly in that. Hospitals are going to dominate the post-acute landscape. Post-acute networks are going to become increasingly tighter in their usage. Physicians and insurers are going to focus on population health management with a community-based referrals. Referral lists will shorten for everybody. As we said, physician-owned practices by hospitals and health systems are going to look a lot with the information systems. They're going to look at compliance a lot closely. Historically, we've been an undifferentiated industry. We've heard referral sources refer to in the home health agencies as VNAs. They've not looked at them as being any different. The secret here is you're going to have to differentiate yourself. You're going to have to become known for something, and there are metrics and numbers out there that are going to do it for you as people begin to look. We're seeing on the nursing home side that they've been doing this for years, particularly in terms of you may find a nursing home that's really good with wound patients, or they've got the capability of handling vents, or they've got a brand new physical plant that looks like a Taj Mahal, so that everybody who gets a hip or a knee wants to go there, so that they've been looking at this differentiation in order to get a reason to be included in the network. And once you've got that reason, then you can go as part of the network and say, I need X amount of volume to be able to provide my niche, but you got to give me some other cases because I can't survive on only those patients. And that's part of the give and take that takes place as part of this. There are low barriers to entry for this business. There is virtually no capital. All you got to do is fund accounts receivable. So I think we can expect that you're going to see large post-acute providers, nursing homes in particular, and short-term acute add competitive home health and hospice capacity. I think it's coming, and it's going to be up to them. It's going to be a make or buy decision. You're going to have to figure out if they don't have that in-house capacity, what are you willing to do in order to work with them? Are you willing to create a joint venture? Are you willing to give up control? Those are some of the really tough questions you're going to have to ask. We want to give you something of value in addition to having heard me speak, in order to start the process with question 1, which is market maturity for both home health or hospice. We are more than willing to give you a copy of a chart that will give you utilization levels by state historically. For if you'll just send an email to me at rchesney@healthmr.com and request the state-by-state utilization chart with your contact information for either home health or hospice or both, we'll be more than willing to give you that gratis in order for you to begin this process, which we believe is so important. If you'd like to talk about this further, here's an example of the chart. Please, here's my contact information. Please give us a call or send us an email, and we'll love to talk to you about figuring out how you can answer these 4 questions for your particular organization.
We have a couple questions that came in. I just wanted to let everybody know a couple things. We will send out the handouts for you and send a link to the recording. But if you wanted to submit a question, you can do that in the question pane. And I just wanted to, I've been answering them through chat just privately on a few of these, but let me see if I can get a couple of questions out there. So someone had mentioned that they missed the comment about the ICD-10, your thoughts about changes on the horizon, about your comments about ICD-10 being possible threat?
On the ICD-10, I mean, I think Medicare is going to be ready. I don't think that's going to be a problem. But I saw a piece of recent research that said the doctors are only 50% of them look like they're ready to do this. And so I think the risk from a cash flow perspective probably is going to be with some of the insurance companies, in terms of whether they've been able to reprogram their payment systems.
Okay.
So it's possibly a small impact, but, it's something to watch very closely, because if Medicare has problems, you better have a line of credit.
All right. Let's see, just a couple other questions here. Let's see, someone asked just a basic question. Just in a nutshell, your definition of what we're calling value-based purchasing.
Value-based purchasing, broadly spoken, is payment that's based on a performance metric. Okay, for the hospitals, it's some of how much they get paid is in fact tied to what the readmission rates are on certain key DRGs. So that's a value-based purchase item. In terms of they may get more or less based on how well they perform. So it's really tying payment to performance.
Okay. And someone commented, someone who handles a large population of the dual eligible says that they have a huge number of non-compliant patients, that they are finding that's an issue. Have you heard of any type of incentive program to address that, or maybe help the patients to comply with appropriate plans of care? Have you heard of anything with regard to that?
I think that you've got, I mean, there's a reason why we did a dual eligible problem. Okay, they spend a disproportionate amount of healthcare dollars. We know that, and we know that unfortunately they are the intersection of their medical issues with their socioeconomic issues. That is a direct correlation. The issue that we're talking about really needs to be addressed with the dual eligible managed care organization. All right, a lot of those folks are coming into this business from the Medicare Advantage world. They don't understand this population. Maybe if they've done special needs, they're a little bit knowledgeable, but they do not understand the socioeconomic issues that are tied in with these dual eligibles, which are really the end product of that is this non-compliance that the questioner is talking about. Yes, it is a reality, but it's really going to be so that for the home health agency, it is really incumbent upon them to be the educator of the managed care organization as to what the problems are, what they've seen. They probably know more about this population than the managed care folks do on a day-to-day basis. And it's really for them, and this is their opportunity to say, yes, we can do X, and you're going to pay me Y for that. But that's not going to solve our problem because we're going to have all these other issues. All right? Here are all the other things we need to begin to do, and therefore we will, we need to pay me more. The secret to this, for this dual eligible population, and really where there will be a merger between personal care and skilled care, we believe, is in the opportunity to take your personal care resources and use them to deal with some of these non-compliance issues. And so it will be an integrated care model between those two areas that is going to be most successful in impacting these patients on a day-to-day basis. Those care resources that are in the home know a great deal about those patients, and there's a lot they can do. So, you know, if you're in the skilled business and you're doing, you know, and you're dealing with dual eligibles, you need to be in the personal care, or the what we call, I hate the words, private duty business, in order to really cross-leverage your resources. And you need to be coming to your managed care providers there with programs that can address those issues. The ultimate goal here, and we've got some data on this, is basically figuring out a way to reduce hospitalization rates for those populations and keep them out of the hospital. And that, you know, maybe it means going at risk, right, and say, pay me X, but if their hospitalization rate is 15% and I get it to 12, and that saves you $4 million, give me $1 million of the $4 million. I mean, it's a whole new way of negotiating. It's a whole new strategy. It requires a lot more information to go to the table and present this. Now, are you going to get accepted with open arms? No, because this is radical. This is new. This is different. But you know, you can let them struggle on their own for a while, and at some point, if they start not making the money they think they're supposed to make, they may become a lot more receptive. I hope that answers the question, Rob.
That's a lot of information, and that's very valuable information. That's all the time we have, and if you wanted to submit other questions, we can answer them privately, but we appreciate everyone's time today. Rich, thank you very much for the presentation. For everyone who's on the line, we're going to give you an email follow-up with a link to the recorded version of this webinar, a couple of handouts. You have Rich's email that we handed out earlier. We'll send that as well. If you wanted to take him up on the offer of the chart of utilization in the different states. If you'd like to see more information about ContinuLink or IGEA, we can offer you that as well. So thanks again, everybody, for joining us. If you don't get the email, I just wanted to remind you that, or even if you do, just bookmark ContinuLink.com and you can check out the webinars, see what's coming up, and view past recorded webinars. They're all available there. So that's it for today, and we'll be sending out more information, follow-up, more information on upcoming webinars, and thank you again, everybody, for joining us today.